committee room.
Welcome to the Scottish Affairs Committee. We're delighted that you're able to come and give evidence to us this morning. Obviously, we know that our predecessor committees have looked into this issue, or at least the issue of problem drug use, in some detail. So we're very interested to find out a little bit more about the ideas behind the Safe Drug Consumption Room in Glasgow, and obviously eventually to see how that works out in practice. I know some of you have been to the committee before, but for those of you that haven't, we are broadcasting now, and otherwise the committee's a very relaxed place. And if there's anything you don't understand or we're not making ourselves clear, please don't hesitate to ask us. I would just ask that all questions and all answers are directed through the chair. So we'll now begin, and I'll kick off. I wondered if you could give us an idea what you think the root causes and the structural drivers are of problem drug use. I'm sure we all have our own thoughts and ideas about that, but it'd be really interesting to hear your views as people working in the field. So I'll go to Gillian first, if that's okay.
Well, I would like to, if I may, Chair, I think there is a lot to sort of consider here from the specifically Scottish perspective, but on a more general point, sort of thinking through, there are structural drivers like poverty, deprivation, we have high levels of trauma, not always the available mental health supports to deal with that trauma, and this trauma through the life course as well for individuals. And so there are a range of sort of wider factors, not just at the individual level, that drive substance use particularly.
Would anyone want to add to that before I move on?
There's lots we could add to add some layers onto that from a Scottish perspective, which I'm happy to do, and I'm sure Andy will have some thoughts on that too. Gillian has mentioned the deprivation and poverty, and I think in Scotland in particular it does stem from a period of deindustrialisation in the 70s and 80s, and at that time heroin did get into, kind of penetrated our more deprived communities, and we're seeing the legacy of that now. It does mean in these deprived communities, as you'll appreciate, there is more mental health problems, there's more problems with housing, welfare benefits. It then creates communities where children are more vulnerable. And another factor to think about in relation to children and the intergenerational aspect of drug use in Scotland is that more children were removed from their families and their parents in Scotland in particular in comparison with other parts of the country. So adverse childhood experiences play a role, and they certainly play a role in how this has gone through the generations. One other structural factor, if I might mention, is around funding and support for the services that you would hope would wrap around people in these communities and provide the support needed to help them through. And funding has been challenging, and funding for drug services in particular was reduced around 2015, which was just at that critical point where various other factors were coming together, and we were starting to see that really sharp spike in drug use. So there was a bit of a perfect storm, if you like, of factors around 2015, which really increased our drug deaths, unfortunately, very considerably.
I just follow up on one of the points you made there, which was about, if I understood it correctly, children being taken away from their parents more often in Glasgow perhaps than in other places. Were there, I'm struggling to think what the reasons for that would be.
In Scotland, I think it's a Scottish feature, it's not just about Glasgow, but right. Yes, it is where there was drug use in families, and I think it probably comes down to some legislation around children, protecting children, that was prioritised, I suppose, looking after children rather than, the family unit and supporting the family unit where there was problem drug or alcohol use in that family.
Andrew, do you want to add anything to that?
The only thing I would like to add, I mean, I support the points that have been made, but obviously a lot has been made about the kind of beginning of the onset of the main issue through deindustrialisation in the late 70s, early 80s. But of course, that population, if you like, has been sustained for quite a long period now, so it's not just that period that's helped sustain it. We've obviously come through a recent period of austerity for 10 or more years, so other kind of wider socioeconomic policies have helped sustain the size of the population of problem drug use in Scotland. And what we see in Scotland is that our prevalence, if you like, the size of that population at risk of all these harms, including things like drug-related deaths, is per population much higher than you see in other countries, not just in the UK but in the rest of Europe. And the evidence is quite clear that when you've got a large population of people at risk of drug-related problems, you will get high counts of these things like drug-related deaths and other drug-related harms.
Tal, do you want to add anything?
To be honest, I think my colleagues have covered everything. Yeah.
Good. Could I just ask you, I think Stephen wants to come in as a supplementary, but I'll just finish asking a couple of points, if that's okay. What would the profile be of someone who had problem drug use? Do we cover all age ranges and societal conditions? Yeah.
Well, yeah.
Trina.
Well, I can give you the profile of somebody who, I can give you a profile of people who are dying at the most harm from a Scottish perspective, and Andy can probably fill in a wee bit more from a Glasgow perspective because there's particular features in Glasgow. So, you know, people that we so just for a bit of background explanation, I do some detailed death reviews in Aberdeen City. I work with them as well as my job with Stirling University. And the profile of people who are at most risk of death from a drug-related harm is people who have been in drug use for at least 20 years, so a long history of substance use and all that goes along with that, the trauma and the experiences that go along with that. Their physical health is not so good because they age prematurely, and they're using several substances, and the areas of deprivation have 15 times more deaths in Scotland than compared to the least deprived areas. So it is concentrated in areas of deprivation. But having said that, you get drug use across all social groups and all parts of the country. So yeah, we should never forget that, but there is obviously a kind of more high profile risk features in also in men. I didn't mention that. Men are more but twice as likely as women to die. Yeah.
Andrew, did you want to add?
Yeah, so just think about the profile, so even going beyond the deaths, so like Catriona said, it generally tends to be men who fall into that problematic side, so it's generally about 70-30, and that's held pretty firm for a long time. We talked about this older drug cohort, or this ageing drug user cohort, which largely stemmed again from the 80s. That is probably been wrongly attributed as being the main catalyst for all the problems. I think it's one of the reasons, but it's not the only reason, because we do see harms across the age groups now. Catriona's mentioned polydrug use, which is a key thing and is quite unique to the Scottish situation in terms of the volume of polydrug use we see in Scotland, particularly compared to other countries in the UK. And the profile of that polydrug use has changed a lot in the last 10 to 15 years. It was very stable in the past, generally heroin, benzodiazepines, alcohol, kind of combination of so-called downer drugs. But we've seen a lot of new drugs come into that mix now, being much more available and much more affordable. Things like cocaine, for example, has radically changed the whole landscape in Scotland, moving from more of a so-called recreational drug to much more into the street drug scene, being injected by huge amounts of people who would traditionally been using opioids such as heroin have largely shifted towards that cocaine market. So the landscape has fundamentally changed, and the profile of users, as well as that older group, we now have what we call opioid naive users, so younger people using drugs problematically who haven't entered that heroin or other opioid market are now coming in straight into that cocaine market. So it's a very complex environment now, much more complex than it's probably ever been, certainly much more complex than it was 10 to 15 years ago. And Catriona's mentioned kind of poverty and inequality. We do have the deprivation component is very strong here, and as Catriona said, drug use is across all of society, but in those most deprived communities, there is limited agency to deal with all the other things that come with that, such as welfare, training and employment that help people cope with the circumstances surrounding drug use, which makes them more vulnerable to addiction and dependence.
And trauma was also mentioned. Is that trauma related to living in that environment, or is it specific traumas around other issues that might occur, or both?
It's both, certainly. Yeah. There's certainly trauma from the environment, and being a drug user brings with it trauma. You know, assaults and involvement in criminal activity, witnessing overdoses and drug deaths, and so there's that. But adverse childhood experience and childhood trauma is something Gillian knows a bit about this as well. So, there is that combination of factors.
Gillian, do you want to add to that?
Yes, and just moving to the safer consumption sort of side of things as well. The profile of people who would use that is around about sort of 30 to 35, a lot of males, very high trauma history there as well. And and probably quite a few people are also very vulnerably housed, maybe in unsafe housing, house of multiple occupancy. You know, by unsuitable I mean things like mould and lack of safety, or maybe not ideal landlords, or those kinds of things. And for some people who maybe aren't housed, then it's basically the stress of everyday living is beyond what I can even imagine. Even things like finding somewhere to go to the bathroom. You know, we as you know, when you're housed, I could nip into a wee coffee shop, but people who are unhoused are often not even allowed to use those kind of public facilities. So it's everything from just where do I sleep, how do I stay safe, how do I get a night's sleep in the cold? It's been very cold here in London overnight. You know, even just that very daily sort of trying to work out how to get through the day can be really quite substantial from a trauma perspective. And from a behavioural science point of view, if we're ever thinking about behaviour change, we're thinking about helping people make more healthful choices for themselves, we need three things, and they are capability, opportunity, and motivation. And if we don't have all those three things sort of intersecting, then we really are struggling to try and help people make those healthful changes. So that's basic. Capability is about the individual, their physical resources, can they move around, their sort of psychological well-being. If you're kind of preoccupied with, you know, how to stay alive, you just don't have the headspace to even entertain possibilities of work or, you know, your relationships and things. You know, it's really difficult. I think for some of the sort of supports that can be provided, opportunity is the real key part. This is about our social resource. This is about the physical resources, and centres like safe consumption sites can do things like even just provide space, like a place to be that's not on the street, perhaps using drugs and things that builds people up and helps move that motivation forward.
Thank you. Stephen, you wanted to come
Yes, thank you, Chair, and thank you, and good morning to you all. Just to take a step back, if we may, you've talked about the economic factors, the legacy impact of that through deindustrialisation. Scotland, of course, wasn't unique on these isles in that context, and across Europe wasn't unique in that context either. But you referred to the growing use of polydrugs and the impact of that. Would you say that there's a heightened concern about particularly young men and their ability to use the likes of cocaine readily, and that leading to the consistency in terms of drug deaths in the future as opposed to a reduction? Because I'm very conscious of the fact that deindustrialisation was 50, 60 years ago. So I'm trying to better understand why we are still in the situation we are when we are so far away from that period.
Yeah, I can answer that, yes. Yes, I suppose there's two parts to that. I mean, I think the deindustrialisation started things in communities, and now we're seeing the generational effects of that. I think that's the point where we are now. But we're also, as you rightly are alluding to, I think, there is other drugs are very widely available now across society. So cocaine is a classic example. It's much cheaper, it's much more available. When you're asking about young men and cocaine, yes, there's very prevalent. Cocaine comes in two forms and is used kind of in two different ways, but there is a very prevalent cocaine use in Aberdeen. It's one area where we have particular high problems with cocaine use across society. So you see it in young men, but you also see it in our communities where there are long-term polydrug users who are using crack cocaine alongside other drugs. But you also have young men who are using cocaine with alcohol. So there are different sort of subgroups, if you like. So I'm not sure if that's quite what you're asking about, that group of young men, and whether you're maybe thinking, are they at risk of getting more involved in polysubstance use? I think we're at that stage. It will be, yes, where we're kind of observing what's going to happen to some extent, because the other drugs that are being used by that group are things like ketamine. So there's this move away from your heroin type substance, but ketamine, cocaine are being used by a slightly different, broader demographic. That's what we're seeing locally in Aberdeen, and I think it does, I've picked up, it does happen in other parts of Scotland as well. So, you know, intervention with that group to prevent them, you know, getting into more entrenched drug use, yeah, it's something that is being considered. It's very much been thought about.
Elaine, you wanted to follow up too?
Just on the back of when you were saying that there was a reduced funding in 2015, but the Scottish Government have targeted areas of deprivation with the Drug Death Task Force Fund. Do you think that's working, given that the drug deaths have went up? So that, I think that was around about 2020, 2021, that funding went in?
Yeah, that didn't target specifically areas of deprivation. It the Task Force Fund, I don't know if you mean a Task Force Fund or the National Mission Fund, but
the peer project.
The peer project, peer naloxone project is maybe what you're...
No, it's a project that's been funded through Scottish Government to support people with lived experience, to support their peers within local communities that are have got very, very high drug deaths.
Yes.
Right. Okay. So do you think that's working, considering the drug deaths have went up?
Okay. So, yeah, I understand what you're alluding to now. So that, no, that's fine. There's so many strands to different projects that were started. So that peer project, yes, it's to develop that living experience kind of community, so that there's a sort of feedback mechanism for people to be able to feed into the development of services and things can meet their needs. And so that's targeted where there are areas of highest drug use. As for whether it's working or not, that in itself we wouldn't necessarily expect to see having a big impact in drug deaths. It's several components and several different initiatives put together. That's where we would like to see drug death, you know, obviously starting to come down. So it's difficult to pick out the impact of one initiative like that, but it's certainly an important initiative to make sure any responses that are taken are meeting the needs of the client, those most at risk.
Is it on this, Angus?
What's on drugs?
Doesn't make it any easier for me to decide whether it's a supplementary or not.
The problem that I can't see it anywhere else in here, but it would seem to be the crux of the question. The trouble is...
I do want to hold it for a little bit later.
Okay. Yeah.
Right. Elaine, you've got the next question, I believe.
Thanks. So could you outline the key differences between the criminal justice system and the health-based approach to problem drug use? That's to any of the panels.
With that one.
I can have it. Yeah. Well, so I would say a criminal justice based approach is focused on really trying to punish and address drug use per se, whereas a public health approach is focused on trying to address the health-related consequences and make sure that people's health improves. Generally speaking, I would say that a criminal justice-focused approach hasn't been that successful. So I think the committee noted this in their last report, that most countries that have tried to tackle drug-related harms purely through criminal justice haven't made particular progress. I think generally a public health-based approach has had more of a successful track record in reducing health-related harms, but the purpose is somewhat different. So the purpose of a public health approach is very much about reducing the drug-related harms that people experience, whereas criminal justice is more focused on trying to punish drug use.
Given the report published that, is there any, do they work hand in hand, or is there any future of them working hand in hand?
So if I could just come into that one. So yeah, it's a public health approach is what I suppose we would advocate for and what has been advocated in the previous report. A public health report doesn't completely reject criminal justice elements, and I think it's about balance. So shifting towards a public health approach puts the focus on the individual and on communities, and treating health as the number one priority and not enforcement, as Vittal has mentioned. But that's not to say that enforcement isn't still part of a public health approach. It's just the enforcement angle has moved much higher up the chain. The enforcement isn't on the streets to the individual user. In relation to that, when people are engaged in relation to their drug use, they're either signposted to treatment, for example, or other forms of support, rather than being marched down to the police station as a first point of contact and ended up in the prison system. So there's rebalancing of how you would look at that. And certainly some countries who have pursued that approach, Switzerland being probably the best example of how you rebalance your system, have achieved good results in relation to their drug-related harm indicators. So it's not about rejecting a kind of criminalisation approach in favour of public health approach. It's about rebalancing the focus to that while still maintaining an element of enforcement, but perhaps moving that up towards the supply side of things.
Gillian, did you want to add to that?
Yeah, and I just want to sort of bring in, I think these things can work together. So we know from looking at the global policy picture that there are the United Nations global drug policy doesn't actually prohibit like harm reduction services. So it kind of recognises that intersection between policing and the criminal justice system and health. And it doesn't necessarily go against the convention so long as the purposes of facilities for harm reduction are indeed health focused. Also thinking a little bit more about the policing perspective, and through my work I've spoken to quite a few forces across the UK and in Scotland about some of the frustrations that they see in sort of dealing with possession related offences, how much time it takes for officers, how many times they see people on a repeat for things like possession, and so sometimes the kind of more decriminalisation approach where you're speaking with people and you're kind of maybe taking more of a health-led approach in that respect, with some good examples of pilot work here, I think in Durham and Thames Valley and in other places around the UK. I'm not sure if there has been one in Scotland, and sorry, my apologies if I didn't know that. But I think there is a way for these things to kind of coexist and to protect communities, which also includes people who use drugs and the police officers who work in those communities.
I think Stephen?
Yeah, so just to build on that then, could you perhaps illustrate to us the differences in approaches within Scotland and elsewhere in the UK, be that England, Wales or Northern Ireland, and perhaps go a little bit further and explain where you think there's been successes but also learnings that could be had.
Is that specific to the public health approach?
Criminal justice.
Well, I think an obvious example with the public health approach versus the enforcement approach. So the Police Scotland naloxone programme is a good place to start. So That's effectively a public health approach to policing. So that's bringing in a public health intervention to a workforce who are traditionally used to enforcing the law, and that's been a hugely successful endeavour, which is now was initially piloted, but like the consumption room, and has now become part of national policy through effective evaluation and then implementation in there. And I think that's something that maybe we couldn't have imagined would have happened 10 years ago, to see police carrying an naloxone kit as part of their routine daily equipment. So yeah, and then Gillian's mentioned, I think cannabis legislation is another area where we see, not just in Scotland but the rest of the UK, we now see low-level cannabis offences. There's no longer the same enforcement there. There's perhaps a kind of pseudo-decriminalisation approach to that, where people are not punished for those and diverted in different ways. So there are, although we don't have decriminalisation in the UK or any of the devolved nations, there are aspects of that where we're either getting the police involved in public health approaches, or where specific offences are being managed in a different way in approach to that.
Nicholas, would you like to come in?
Chair, can I ask you then, do you still see value in relation to the criminal justice approach? Because one argument for that would be that Scotland and Glasgow in particular specialises in relation to quite groundbreaking treatment of those who are prosecuted in relation to drug treatment testing orders, which are Scotland-wide, but Glasgow in particular has the Specialist Drugs Court, which to my mind is unique. It's been running now for several years and has achieved major success in relation to tackling the drug problem in Scotland. Ask your view on that.
Yes, I know, and in a way that does bring together, I think even in the development of that service across the country, there has been a kind of public health element brought into it, if you like. So it has been successful, and I know there's certainly, although it probably is due some more kind of evaluation, just because the evaluation of it is quite old, but it is generally considered to be a useful tool that the criminal justice is open to criminal justice services to use. So, but even they do build in kind of a more public health way of delivering that, I think, which is important, and they are considering the individual and they are considering their health as well in how that's actually delivered. So, you see it at a kind of local level where you have someone on a DDTO where they've got a lot of support, maybe from a criminal justice social worker that they might not otherwise have had. And actually that kind of level of individual support, not just from a health aspect, it is about those broader issues that we've already alluded to around housing and welfare, etc., can really be quite useful for some individuals. So we're not, I think
well, quite, because it effectively offers that wraparound engagement with broader services in relation to housing support, mental health support, welfare support. Is that something you can see the safe drug consumption rooms developing as well, and offering that rather than just being a service to facilitate safe drug use? Are there the complementary services around it?
Yeah, absolutely, yeah. I mean, others can talk about that in terms of the Glasgow service and the evidence from other parts of the, other services elsewhere. But I think, and it's not just, if I can broaden it a wee bit before I hand over to colleagues, anywhere where there's that kind of wraparound support is crucial. Our drug treatment services really need to be able to provide that, and they're not, because they're under-resourced to do so, and that's crucial. So criminal justice offering at the moment through DDTOs the Safe Consumption site is planning that and will be doing that. But we also need to be able to do that within our general treatment services to a greater extent than we're able to currently.
Just as a point of information, it's important to recognise that the Safe Consumption Room is not planning to do that. The Safe Consumption Room already offers that wraparound service, so it's already in site, or on site, should I say. Whether that's the uptake of that, we'll have to wait and see. That will need to be found out as things play out. But that wraparound care is available on site. It's not simply a facility for people to go and inject. There's a whole host of other services there available to people should they choose to engage in them. So it's very much part of the original framework.
Excellent.
Sorry, Gillian.
Sorry. Please. Thank you, Chair. So there are, if we're thinking about sort of wider facilities that might exploring those across Scotland, there tend to be 4 types. So you have a standalone service or an integrated service, which would have those kinds of, standalone would just be the sort of consumption space, and there would be some aspects on site, but others would be by referral to other partners. There's also mobile sites if you've got quite a dispersed population, so you'll be wanting the mobile to go around those and provide those services, bring those services to the people in the community. The other one is temporary, which we kind of don't really want to talk about because temporary services sometimes are, you know, it's people will get engaged with services and engage with the services, and then they disappear, and then people sort of peter off into nowhere. But they are, the whole part of this is to really connect people to welfare services, connect people to healthcare services, and it's really about building up kind of trust, social inclusion, safety, and creating that space where that can happen. And if somebody says they're ready for treatment or they're ready for some kind of intervention, the staff, and I've been very fortunate to speak to the managers at Glasgow, the wheels just come straight on, and everybody's sort of heading towards helping that person get to where they want to go. So the second somebody says they're ready for something, we want those services to be ready and raring to go. Thank you, Chair.
Thank you. Just following up my colleague's point there, and maybe something you don't feel is in your remit to comment on, but we've had, as Douglas says, the drug court in Glasgow for quite some time now. Do we need to roll that out into other parts of the country? Would that help the situation? Feel free to say that's not for us if you don't think it is.
I mean, there are DTOs in other parts of the country. The drug courts, I think, is a bit different. So yeah, I think I'd let somebody else answer that.
That's okay. We don't have to have an answer to that one. That was a bit. I realise it's not quite in your remit. Maureen, I think you're going to ask the next question.
Thank you, Chair. My question is that how do safer drug consumption facilities seek to reduce drug-related harm? And the caveat to that as well would be, what services are often provided within such facilities internationally? I'm not sure who would want to respond to that.
I'm happy to take the first bit and then maybe move to you, Gillian. So the concept of safer drug consumption facilities is fairly basic. The concept is that you have an identified problem, which is people using drugs in public, particularly people injecting drugs in public, and you're aiming to move that public drug use indoors, away from the communities in which it's happening. So public drug use is bad for the individuals who are engaged in it. It's unhygienic, it's dangerous. It's also bad for the communities in where it occurs because of things like drug-related litter and worries about a public nuisance that goes alongside that. So by moving that issue indoors, first of all, you can treat the danger to the individual themselves. You can give them a safe, sterile environment where they can engage in their drug use, particularly their injecting drug use. You can provide on-site support in case they get into any particular harm, particularly overdose-related harm. You can also provide on-site treatment and care to deal with complications that come with public drug use, like skin and soft tissue infections, for example, and other potentially mental health support. And then, as other people have said, should people be willing at any point to engage with a wider array of services, such as recovery services or treatment and care services, then there's a pathway for people to engage in that through the service itself. And then for the wider community, in theory, that public drug use moving inside should reduce the amount of drug-related litter that people are exposed to on a daily basis, reduce the amount of people they see using drugs in public on a daily basis, whether they live there or whether they work in that area, which is difficult for people living in those areas. So it addresses both the individual needs, but also addresses the community needs in relation to the problem that's occurring in that area. And that's why they're most effective if they're located within the kind of the hotspot really of where that public drug use is occurring.
Thank you for that.
Just to come in off that, a few extra little points there. I think we've talked a little bit earlier on about some of the issues around marginalisation. So some of the facilities would also have things like tea, coffee, some food, places where people can do laundry. So if you're vulnerably housed, you mightn't have somewhere people could be wearing socks, same pair of socks for 3-4 weeks, you know, things like that, fresh clothing, those kind of things as well. And also there's a public health surveillance sort of function as well. So we don't talk about that as much, but it gives sort of wider interest holders some knowledge, policing, public health professionals, local treatment services as well, a bit of an idea of what's going on in the population as well, and maybe how they can respond. And the other part in terms of communities is as well is that they tend to either have no influence on crime rates compared to control areas, or there's usually a slight decrease, and that's based on evidence in Australia, Canada, and also some emerging evidence coming out of the USA as well. So there's a wide range of community and individual level benefits there for these services.
Thank you. Thank you.
We're on to Angus now.
That actually leads perfectly onto my one. The international experience is clearly something everybody is looking at. Has there been a very noted improvement in areas where they have got drug rooms around the world?
We completed a very large evidence review back in 2023, which summarised the evidence from around the world, including summaries of 35 different reviews on different topics. And it certainly would be the case that we're seeing some major improvements to communities. That's not to say that when these services open, there aren't teething issues and things evolve over time. I'm not going to pretend that it's all rosy in the garden, because it's definitely not. But that it's really about that partnership working. Police are key partners, public health are key partners, health professionals, people running the service. You need to speak to the community you're hoping will come to your service. That's a really important partnership. And when all those things are in place and those legal protections are there, and that kind of partnership with the police, and you were talking about the criminal justice and health intersection there, and when those things are in place, then it does seem to be effective. That's not to say sites do and do not close. There's often sometimes political shifts in the wind, if I put it that way, politely, that can mean that services close despite evidence. And sometimes some services close because there's no longer a need for them to be open. So, that the issue that led to being open in the first place no longer exists. There's around 200 facilities in, I think, 19 countries. The numbers always vary, so it's kind of a rough estimate, including the UK and Ireland now.
Lillian?
Just on the back of that, Gillian, just what you said, that in some cases services close because it may be that there's not a need for them anymore, so that would suggest that they're successful. Yeah. Can you give me some examples of areas where the services have closed? For those reasons.
So I think sometimes services can't evolve into different sort of spaces. So things like injecting public drug use. Sometimes people move on to things like smoking, so that it can be a sort of shift in facility. So it's no longer dealing with an injecting drug use problem, it's dealing with a different kind of problem. I can't think off the top of my head of the countries, but I can contact Lulu with more details, if you don't mind my helpful. But it's quite rare that happens, just so you know. So if you've got this idea that we're going to open these services and then everything's going to change, but the evolution of a service has to be very much part of services like Sydney, that's been open for 21, 22, 23, 24 years now. That is not the same service that opened its doors. It's had to evolve to the changing needs of the population. Sometimes things, they'll go mobile. I sort of mentioned previously about needing to move around the place, maybe less in that sort of fixed place, and maybe the mobile sites will have to go out and serve the community in that way. So if it's not designed to stop drug use, that's not the purpose. It's designed as a harm reduction intervention.
Yeah, I understand that. And just
Chair, if I may, so based on the services that are the international services, I mean, are they 24-hour facilities? I understand the Glasgow facilities 9 till 9. My experience, I have a background of NHS, my experience of addicts are very chaotic lifestyles. They will not stop injecting after 9 p.m. at night. So I'm just trying to find out, what is the view in other countries in terms of opening hours, the service provision. Is it more tailored around the sort of lifestyles of people that are addicted to drugs that need the vital service that it provides?
So that's a very good question. That very much varies. Tends to be the unsanctioned temporary sites that open 24 hours. I can only think of sort of maybe 1 or 2 off the top of my head. The other services that are sanctioned tend to be open as a function of capacity to pay for staffing and properly resource these sites, because one of the key aspects obviously is observing the consumption event. You need to make sure people are there. There needs to be enough people if there was an overdose that there would be enough people to deal with that and to support the others that are there. So quite often it comes down to a situation of resources. We were talking a little bit earlier about sort of closing of sites and evolution of sites. So a good example of that would be Zurich in Switzerland. So in Zurich, there's a number of different sites across the city. I think there's 4, 3 or 4, and they open at slightly different times. Now, this is a little bit unusual because there's quite decent transport links to get people around and to try and sort of so people can move around the city and afford to do so. That's that psychological or that opportunity that people have for behaviour change. So again, it's really about evolving the model to the resources that are there, to the needs of the people, and trying to serve the community as best you can with the resources you have. There's very few 24 hours, and of course, then we would have risks with people overdosing at home or in the streets and so on afterwards. So it is. We talked previously about wraparound care and sort of thinking through different aspects, and it's really about sort of looking at housing provision and even digital solutions like watches that can detect overdose response and things like that these days as well.
Gillian, you have a supplementary?
I was just going to add to that.
Sorry, Andrew. Sorry.
Just the key thing to see is that the consumption room is not. It's not the only service. It's not a magic bullet for the individuals it serves. So you've rightly highlighted that people might be engaging in these behaviours beyond the opening and closing hours of the facility. And as Gillian's rightly said, it's one part of a whole system, which involves not just the consumption room, but involves needle and syringe exchange. It involves the treatment and care system. It involves the naloxone intervention. It's one part of a whole system designed to reduce harm amongst these individuals, and often opening times are a pragmatic decision based around funding, based around capacity. And a key point I'd like to make is it's a pilot. So once the service starts to establish itself, I think it will quickly become clear what the kind of busy points or the main utilisation points of that service are. So there is potential for the service to evolve and adapt to how it mainly operates. That's not to say it's going to be 9 to 9 forever. It might change in relation to that, based on, like you say, when people are most likely to use it and when you get most efficient use of the service. So it's important to bear that in mind, that it is a pilot, so there's potential for change or flexibility there.
Just going back to those international comparators, in terms of harm reduction as a benefit of the safe drug consumption facility.
Can you speak up, Stephen? Speak up. I can't hear you.
Okay, Angus, I shall speak up for you. In terms of the international comparators, in terms of harm reduction, I'm very conscious that the facility in Glasgow has only been open for a matter of weeks. How long, what sort of timescale was it internationally with our comparators in terms of being able to assess whether there had been a significant harm reduction as a result of the facility being there or otherwise?
Well, I can, yes, maybe it's a good time for me to mention the plans for an evaluation and what when results might be available for Glasgow specifically, and then I can pass back over to Gillian in terms of the timelines more generally. So it's possible to find out quite relatively early in terms of, from the point of view of research, whether the service is being implemented as intended, whether people are engaging with the service, whether it's getting the reach of the right type of people. So often the people that the facility is really trying to reach are people who are not engaging with current services. So we can get a sense of some of these, if you like, process measures fairly quickly. In terms of actually tracking things through to things like the amounts of overdoses, ambulance call-outs, these types of measures that you might view as kind of harder health outcomes, that can often take some time, and it depends a bit on how big the service is, how many overdoses normally occur, and so forth, in terms of having the amount of numbers to conduct reliable statistical analysis. But that will probably take more in the order of kind of 2 or 3 years to actually be able to develop that type of evidence. But potentially even longer than that in terms of it then going through peer review and being published and so forth. So I think you can get early indications of success in terms of things on the pathway to improvements within a couple of years, but in terms of actually demonstrating real reductions in drug-related harms, it's probably more in the order of kind of 3 or 4 years, but thereabouts.
Kind of fit with what we've seen elsewhere then, yeah?
Yes, very much so. And I think one of the things to really recognise about this population is that they're quite often not engaged with services at present. There's quite a lot of issues with trust, sometimes of the police, sometimes of healthcare services. And we've heard of some stories around individuals who've been to hospital and then been denied swift access to things like opioid substitution therapy, which discourages them from going, so they may have that sort of mistrust of the NHS, unfortunately. So it takes time to build those relationships to get that harm reduction to happen. And really the mechanism by which safe consumption sites work is through sort of safety, trust, inclusion, and building those relationships with the healthcare staff and the staff on site. So we're really looking at sort of engaging those high-risk substance users, not people who want to inject perhaps for the first time. That's not the target population. These are people maybe with long career histories. And the more we can engage them and the more they attend, that tends to be where we see the big harm reduction benefit. So the sort of early piece is really about understanding how they're perceiving it, what can we do to change the service. Again, we've talked about evolving the service a couple of times here. And the more we get people to attend, that's really where the magic happens, you know.
Just in terms of drawing conclusions, I guess you'd be wary of politicians of any ilk seeking to draw conclusions as to the success or otherwise for a considerable period of time in order to let the pilot expand and meet the needs of the people who are using the facility. Yeah,
I think one of the core elements of the Lord Advocate's permission for the facility to operate is that there was an independent evaluation to take place. So I think that's where politicians, members of the public, other key stakeholders should be looking to judge, looking to the findings from that alongside other evidence to see what impact the services had once that independent evaluation has concluded its business.
Good.
Obviously the Lord Advocate is a key stakeholder in all of this, and there are other key stakeholders. I understand some of what you're saying about the evaluation, and clearly that will be incredibly important. But do you know, I presume they've given you a clear idea of what they're actually looking for from you in terms of, or from the independence of the evaluation? Have they set that out very clearly?
So I would say that from an evaluation point of view, so there's a research team that's planning an independent evaluation. And that team involves researchers at the University of Glasgow Glasgow Caledonian University and others. The team's engaged with a broad range of stakeholders to identify what the suite of indicators of success might look like. So it's not going to be a single metric. It will be an assessment of what are the range of potential benefits and trying to quantify those different benefits, including things like, is the service engaging people who haven't been engaging in services, as well as some of the kind of harder reduction health in drug-related harms, like, for example, overdoses and so forth. But also looking at evidence of, are there potential adverse impacts on the local community where community members have raised specific concerns that are being investigated. So as a member of that team, so we've not directly contacted the Lord Advocate, partly to try to ensure we do remain independent. Yeah. But we have been seeking input from a broad range of stakeholders, including the local health board, the police and so forth, to identify what are the key indicators that people would want to see evidence around.
Very helpful. Elaine?
I think this will be for Andrew. So how can the Safer Drug Consumption Facility combat the spread of bloodborne viruses?
Yeah, so another important point to remember is the proposal for the Safer Drug Consumption Facility. It often gets confused as being a response to Scotland's drug death public health emergency. But actually the proposal predates that by a number of years. The proposal for the Safer Drug Consumption Facility was partly in response to the HIV outbreak amongst people who inject drugs in Glasgow City. So there was a needs assessment carried out in relation to public injecting. And there was various proposals made on the back of that, the heroin assisted treatment service, enhanced IP provision, etc., but the drug consumption facility was part of that proposal. And obviously HIV was being transmitted as a bloodborne virus between people who inject drugs in the city through sharing of contaminated injecting equipment. So it was a proposal directly in response to a bloodborne virus outbreak, and it's important to remember that. Now, that outbreak is now thankfully under control. It took many years for that to be officially announced to be under control, but there is still a huge risk within the city, because although many of the people involved in that are now engaged in treatment and their viral load is under control, there's still a risk. The reservoir of infection, as we would call it, is still very high in the city should individual circumstances change and then transmission events occur, so we need to bear that in mind. So the importance of that incident is still relevant to the service. So a bit like I said in answering Maureen's question earlier, by moving that consumption indoors, you immediately remove one of the key risks for bloodborne virus transmission, which is the sharing of contaminated injecting equipment, because there's no permitted sharing of equipment on site, no permitted sharing of drugs on site. So people are immediately engaged in kind of safe, sterile injecting drug use. So you remove that. Plus you remove a lot of the other factors that make public injecting risky to the individual. Like I said, people are often rushing when they're doing it because they're for fear of being caught by the police or a member of the public. They're in very unhygienic circumstances. And then there's also the opportunity for people when they're in the service, should they wish, to be tested for bloodborne viruses. So they can be tested for HIV, for hepatitis C, for hepatitis B within the service. And one of the huge successes of the response to the HIV outbreak was a huge upsurge in bloodborne virus testing within Glasgow City. Glasgow City was really at the bottom, probably, of the kind of national average before the outbreak, and has now risen to probably nearer the highest levels in Scotland for bloodborne virus testing amongst that at-risk population. So yeah, the service should definitely make inroads into bloodborne virus prevention, provided it's utilised to a sufficient level.
Just will that be reported in your independent report? Yeah.
Yes.
Yeah, that's absolutely one of the indicators that would be included as part of that. Yeah.
Thank you.
I think Lily, you'll be next.
Well, that leads very nicely onto my next question, which is really about the safer drug consumption facilities offer value for money, considering the impact that they have in addressing problem drug use. For example, in terms of cost savings for treatment of health issues, BBVs such as HIV and Hep C, and from the expected savings, I imagine the NHS and Health and Social Care Partnerships have had these discussions and what they're hoping to save in terms of treatment, because it's quite a costly treatment for HIV, as well as Hep C and the demands and the pressures on our National Health Service. So what are the sort of hoped savings, cost savings from the value for money in terms of the drug consumption facilities that can offer against what the cost of operating the facility annually is? And I'm hoping, I'm guessing it's huge, but has there been some work on that, some numbers that you can offer, that you can share with us?
Evaluation plans first.
Yeah. A key element of the planned evaluation is to look at the costs and benefits and trying to quantify not just the short-term costs, but think about the longer-term potential savings, both to the NHS, but also more broadly in terms of broader public sector services and so forth, so including things like criminal justice and housing and so forth. One challenge within the broader existing evidence base is a lot of the evaluations of kind of costs and benefits have been based on quite a limited number of locations, and it's unclear how those costs and benefits will apply to the UK setting. So it's difficult for us to give you an estimate for the Glasgow facilities specifically at this point. I think we will need to do some of the actual research to figure out what are the costs of the facility overall and what are the
early days. In terms of your research from international studies,
may I come in? So the research in this area is quite diverse, and again we're looking more at Canada, USA, Australia for sort of estimates. Now I am not a health economist, so this is a figure that I've kind of brought together based on my reading, and so take it with a big pinch of salt here, because there's lots of different ways in which you can calculate this, and I'm not fully across all of them, but broadly speaking, in terms of US dollars, where I've converted things from Canadian dollars and all the mad sort of differences you have in fluctuations in currencies, it's roughly around, for every $1 spent, somewhere between 2, 7, 8 maybe US dollars saved. Now this depends on a lot of different things. It depends on the cost of the facility, how much it costs to run. Medical-led services are more expensive than nurse-led or peer-led or drug worker-led services. It depends on the services that are provided there. Things like HIV and hepatitis prevention, treatment and support, very expensive to the taxpayer, so if we can change anything on that. Also, overdose deaths are very expensive too, and emergency healthcare, and those tend to be the things that they're counting. What they're not counting is what you've brought up as well about this idea of prevention. And one of the things that we see as well, it's not really part of the numeric figures. Maybe the health economists and we need to kind of come together a little bit more about some of these sort of more delicate aspects. But even things like, seeing some wounds that they're starting to look like they're getting infected, and you don't want it to get to the point where you have something really costly like sepsis, amputation. You don't want people going in for long-term stays, and you want to try and prevent that if you can as well. So it's a very ballpark figure, but in nearly all the facilities that I've had sight over in terms of the health economics, it is saving more than it's costing. There was a recent review by Behrens et al. In 2024, which looked at services, and I think there was one that was fairly cost neutral. I haven't really got the details of that on my hand, but I can connect with the team about that. But again, I think it's quite rare that that's the case, and I think a well-run service with good, high-quality, standard operating procedures, which is the kind of thing that I've been seeing through my conversations with Glasgow team, I think there should be some savings to be had. One last thing is that, just to note for Canadian figures and US figures, they very much have fentanyl in the drug supply, so it may be that their numbers are a bit higher in terms of the cost savings as a function of that. Although we're seeing synthetic opioids coming in, like nitazines here and there, a great concern for everyone here on the panel and anyone working in the sector, it just to sort of temper your expectations in terms of what we might find, and this evidence will be really useful to model.
I mean, I think you can be reassured that Glasgow's it's fairly strong, well placed to evaluate the economics of it. As Vittal's highlighted, the gaps and the limitations of the evidence base, Glasgow's well placed to address a lot of those gaps because of the infrastructure, not just with the service but with the data as well.
Thank you. Douglas, you have a supplementary?
Thank you, Chair. In preparing for this morning's evidence session, when I was reading, I had picked up that we were currently going through a 30-year high in Glasgow in relation to an outbreak of HIV attributed to those injecting drugs. But in your evidence earlier this morning, I think you were advising us that perhaps that's slightly outdated, that those figures that I was looking at are maybe 2021-22. Are we seeing those numbers coming down, and if they've come down before the safer drug consumption facility has been made available to Glasgow, is that because of the provision of clean needle supply provision, for instance? So some will say, is Glasgow still the right place at the right time? Do you see your safer drug consumption facility effectively making further inroads into that and building on that reduction? And is it also not just in relation to bloodborne viruses? Is it about the safe levels of the drug being injected by the user at your facility as opposed to on the streets?
So in relation to your point about the 30-year high, so that's still a fact. So the Glasgow HIV outbreak amongst people who inject drugs was the largest the UK had seen since the 1980s, since obviously Edinburgh and Dundee were the most focal points for us in Scotland, but also elsewhere in the UK, including here in London. So the prevalence we reached in Glasgow at 11% at that time, we hadn't seen anything like that in that population. So that was a re-emergence of an old infection for that population through a range of factors that created the scenario for that to re-emerge, like homelessness, the surge in cocaine injecting and public injecting, like I've said. But as I mentioned earlier, even that outbreak was declared formally under control within the past few months, and that's because the number of new infections attached to that outbreak had largely reduced to either 0 or 1 over the last few years. So there was an assessment made by the incident management team that the outbreak was now fully under control. There's also been a huge number of evaluations looking into the response to that outbreak, not just the drivers but the response, and a couple of the main factors that came out that were mainly responsible for bringing the outbreak under control were the increase in bloodborne virus testing. So the testing, getting that up to a sufficient level made the huge difference, and also specifically the repurposing of the HIV treatment model. So HIV treatment was moved away from Gartnavel Hospital, where HIV treatment was generally delivered in Glasgow, to a more community-facing model within Glasgow City, so taking HIV treatment to the pharmacies and other services that people inject drugs in the city engage with. So that very quickly increased treatment engagement numbers overnight from a very low percentage to a very high percentage. And in combination, that bloodborne virus testing, prevention, the enhanced IEP, but particularly that treatment model, were successful in getting that outbreak under control. So I think your question is, has the drug consumption facility come too late because that outbreak's under control? I think what I was trying to highlight earlier is HIV is just one of a number of issues facing that population in the city. HIV was one of the most recent and one of the most high profile, but they've also got very high levels of hepatitis C, very high levels of skin and soft tissue infections because of this public injecting they're engaged with. Glasgow City is the highest overdose rate in Scotland. So sometimes it's what we call in academia, there's a syndemic, so there's multiple epidemics at one time happening within a very specific population. So there's a syndemic of drug-related harms affecting people who inject drugs in Glasgow City, very particularly affecting people who inject drugs in public places, and those levels of drug-related harm haven't gone away. So the case for the facility is still as strong now as it's ever been. There still has to be an enhanced response for that group.
I guess over to you.
I wonder how the local community were perceiving the impact of antisocial behaviour as a result of this opening, and do we have any feedback from the international experience on antisocial behaviour within an area of drug rooms?
I can maybe say something about the local community in Glasgow. So I think inevitably the response will probably be quite varied between people. So there certainly has been an extensive amount of work done by the local health board, running community events to listen to people living in the area and hear their concerns and think about how best to address them. So there seems to be a relatively small proportion of people that have expressed a concern about the facility being opened. And as part of the evaluation, we are going to look at what happens to people's experiences of the local community. Do they find that those concerns are borne out or not over time, and compare what's happening in the area around the facility to kind of other comparable areas of Glasgow. In terms of the broader international evidence, my impression, and I'll let Gillian add flesh to the bones, but my impression is generally the communities have found that the local environment tends to improve. So often there's a reduction in drug-related litter, those types of things, and concerns around crime and so forth tend not to be borne out. But of course, different contexts might experience different things, and because this is the first facility in the UK, I think it's still important that we look at that as an independent kind of research team. But the broader international evidence so far seems reassuring in terms of that not happening elsewhere. But it's probably been a bit less studied than, say, the impacts on the people who actually use the facility themselves.
Can I come back on that one as well?
I think Gillian might have wanted to come in. Did you, Gillian? Sorry if you don't.
I
that's
can
fine.
come in after
No,
Douglas.
okay, Douglas.
I suppose the obvious question is how do we prevent it becoming a magnet for drug dealers and drug suppliers? I mean, this is not a crime exclusion zone that we're introducing, is it?
I think an important thing to remember is there's already drug dealing and public drug use happening in that area at quite an extensive level. I think anybody who's been in and around that area would recognise that, and I think that's one of the reasons why people who live and people work there have got concerns about this and have raised concerns about this. So it's already happening, so I don't think we would be importing something into an area where this isn't already happening. And I think that's one of the reasons why the location has to be within that hotspot area, because you have to have it in an area where people don't have to travel large distances to get to it, because the likelihood is that people won't travel large distances to access a facility for this. It has to be a short walk from where this behaviour is already happening. So the location itself is in an area where that's happening, so I think it addresses that point. What you're, I suppose, suggesting is this so-called honeypot effect. Will it bring more people to the area? And I think that's a genuine question to ask, and I think that's something that the evaluation will consider, is about whether more people come to that area. And certainly Gillian might want to reflect on the international evidence. My understanding of it is there isn't a huge body of evidence to suggest people do come from further afield to access a drug consumption room in another area, because people who use drugs tend to stick to the localities. So people in Govan or people in other parts of the city, it's unlikely they're going to make long distance journeys to there, because they've probably got a drug scene in their own area they're already accessing.
Can I come in just with a very small supplementary point to that? In a way, this isn't entirely new. We already have pockets of where drug users congregate and are known to congregate that could, in theory, attract drug dealers. So community pharmacies who have very high levels of service, providing, opiate replacement treatment and supervision. Pharmacies seeing over 100 people a day. So, and needle exchanges, and the drug treatment services themselves. So it's not a completely unique area around this facility. We do already have potential hotspots that can and do, to some extent, attract drug dealing.
Perhaps come in the back of that then and just ask, and being devil's advocate slightly, you wouldn't have a concern then that such a facility would encourage drug use, I presume?
No, I think there's no evidence at all that that's the case. No.
And typically centres would have a plan for somebody coming in to initiate drug use for the first time, in that they would provide them with health and support, and rather than going down the line of facilitating that. It's very much people who are entrenched in substance use over a long period of time that tends to be. May I answer the other international question? So the only place I know where there's sort of travel beyond about a mile, so Douglas, you're sort of talking about people travelling, typically across the world, sites tend to be around 1 mile or of an open drug scene. That tends to be it, because people just don't have the financial, physical health, financial resources to get around much more than that, and whether that's getting on buses or actually physically walking to the space, as Andrew has suggested. There is one exception to the best of my knowledge, which is some travel between Denmark and Sweden as a result, but I think that's the only instance of that I know, and it seems to be very localised and unique. And of course the aspects of these facilities is we really do want high-risk substance users to be coming to these centres as well, if they can, because then they're connected in with other health, welfare, other support services as well. Going back to the communities part, community consultation is an essential part of opening a service, and I believe in Glasgow there has been some essential and extensive consultation with a wide range of interest holders, including those in the communities and business and tourism and all those really important elements of our communities. And I think, there are concerns, and we have to listen very compassionately to people's concerns about what it is that they're worried about, and provide reassurances to people, and to respond when things come. So one of the things I would suggest to people who are thinking of opening new services is making sure there's a designated liaison person, so that if there is a problem, there's somebody to contact. Because usually what happens is they're like, hello, Police Scotland, there's people loitering outside my business premises or whatever, and it's usually the police that kind of deal with some of those issues of moving people on. And there will be, I don't know whether there has been issues, but there will be some teething issues to start with, as everyone sort of works out what's going on, and people who are maybe injecting in public come into this facility. But these are usually ironed out, and we see some really lovely sort of community partnerships. So I always like the statistic. There's one from Sydney that never leaves me. So 18 months after the Sydney facility opened, half of the residents couldn't tell you where it was on the map, and a third of businesses. That's how much it sort of blended into the background, and it sort of just became part of a sort of busy street in King's Cross in Sydney. And that's how, that's really what you want. Similar evidence across Denmark and places like that. Cafes, busy places where people sort of come along and meet their friends and sort of enjoy living in Copenhagen. Very, very much part of the fabric of communities. And the last thing I just want to say is that it's really important for us always to remember that people who use drugs are also members of our communities as well. So consultation with them is really essential to the right service to get people to come in, but also to iron out some of the issues as the service evolves.
Lillian had a supplementary.
Yeah, just in the back of Patricia's point there about the facility attracting more drug use. Just for clarity, I know the answer, but just for clarity, the facility does not provide the drugs. Yeah.
Fine, thank you. Maureen, your next question, I think.
Thank you, Chair. There's a bit of concern that the focus on the harm reduction services, like safer drug consumption facilities, risk overshadow the need for long-term recovery options. What is your thoughts on that?
I'm happy to start on that one. I think we need to think about things as a system of care. Amanda's used that phrase already, but that's where there's different entry points and there's things are joined up. So I would see this as an access point to care and support of some sort, which we hope will encourage people to get drug treatment, which we know is protective, and we hope that that would then lead on to people moving into recovery and support services. So I would see it as a continuum of care that is currently not available to encourage people into our treatment services, and those recovery services that can either work alongside treatment services or can be a support for people beyond. So I don't think it overshadows that. I suppose, yeah, I mean, I think that's probably as much as I would say in the matter. It is thinking of as a system, and rather than one or the other.
Can I ask something on that same subject? On that same subject, obviously this has been a big issue in Glasgow for, I guess, a decade or more. Are we on a trajectory where basically this is not going to become the issue that it is now? There's drug use and drug death and all of that. So much has been put into it and there's been so much effort to reduce it. Are there signs of that we're on the right track and this is not going to become the issue that it is now?
Well, it depends what metric you take to look at in terms of numbers and things. If we look at drug deaths, I mean, drug deaths are kind of levelling off, if you like. Let's hope that continues. But drugs are going to be around and people are going to use drugs. So we need to just improve the way we manage that and support that and give people the options to address their drug problem in a way that works for them. So yeah, I guess there is the hope that overall drugs won't be such a dominant issue in Scotland. It certainly shouldn't, as you can see, compared to other 8 countries, it does rather dominate. So the intention would be, if we get the systems of care right, that will be less of a dominant issue going forward.
So just a quick point to add to that. I would say it's also quite challenging, though, to address the issue of drug-related harms without addressing the underlying drivers as well. So it does kind of take us back to the start of our conversation where issues around deprivation and so forth were kind of emphasised. So we know that within much of Scotland and Glasgow there are ongoing issues of deprivation and poverty. So in the absence of that substantially improving, it's quite difficult to see drug-related harms really being tackled while not addressing those fundamental drivers.
If I could just add to that, I mean, problem drug use in Scotland and indeed Glasgow, it's 40 years in the making here. We're not going to turn around a 40-year issue in a short space of time. I think the consumption facility is an important additional tool in the response, but there's still huge amounts of issues across the range of responses. For example, our drug treatment engagement rates are still not at a level we would like. There are still gaps in our drug treatment response, particularly related to the cocaine issue that we've mentioned. In relation to that, we still have huge issues in relation to counterfeit medicines. Benzodiazepines it's been well documented, and we have the threat of other synthetic drugs coming in just now, potentially nitazine. So I think we've got a long way to go before I think we can conclude that we've got a hold of this issue and we're on a kind of downward trajectory. I think there's still lots of work to do in this area.
Just finally from myself, in that context there's obviously been significant public discourse around the potential for a further tightening of the social security network which exists. Do you believe that that would have a help or a hindrance to the people that we're talking about?
Can I just ask for a point of clarification? What do you mean by tightening
the budget?
So kind of reducing the amount we spend on...
Yes.
Are we asking our witness to effectively speculate on what might be announced in the future?
I think we can accept that poverty is a major driver and that anything that contributes towards
a legitimate question.
rates of poverty. Well, it's a speculation because we don't know that that's the case necessarily.
Okay, I'll reword it. Do you think that if the social security budgets which exist, obviously 70% of welfare spend comes from Westminster, if there was to be a reduction in that safety net which is in place for people who are living in deprivation, who have much more challenging circumstances, do you think that that would be a help or a hindrance to dealing with many of the societal issues that we're dealing with which impact these people and potentially lead to their drug use?
I think hopefully as is clear, poverty and deprivation are really important drivers of drug-related harms. So anything that threatened addressing poverty and deprivation could have adverse effects. But yes, that's really hopefully clear that the importance of kind of poverty and deprivation as fundamental drivers here.
Thank you.
Which I think we understood from the earlier conversation, so thank you for re-emphasising it. Lillian?
Yes, so we've touched on wraparound services, but to what extent is the provision of these services needed to address the root drivers of problem drug use? And does Glasgow have these necessary wraparound services, and are they appropriately resourced and equipped to be as effective as possible?
What to answer, Catriona?
I can make a start. I don't know the specifics of Glasgow in terms of kind of funding, how it's allocated, but in terms of the wraparound services, I think some of the key things that we maybe haven't mentioned, I just want to point out, things like housing are crucial. Stable housing for people is one of these key levers that gives them the safety and stability that you can then start to address other aspects of people's kind of problem. Are those, whether or not those other supports are available in Glasgow, they are available. Whether they're available on the scale and at the level of funding that is needed for the scale of the problem is another question that I can't answer, and I don't know if my colleagues in Glasgow might be able to shed any more light on that.
Anyone want to add anything to that?
I mean, all I would add is that there is a range of services available. Whether they're at the scale required, I'm not sure any of us could answer that. I don't think that question has properly been evaluated yet. There has been investment in a lot of the treatment and care infrastructure over the last few years through the national mission, for example, which Glasgow and other areas have benefited from. But I think the national mission itself is being evaluated at the moment to see whether that increased investment has reached the areas it intended to reach in terms of increased investment in residential rehabilitation, for example, or increase in provision of medication-assisted treatment standards. So I think there is a process in place to evaluate whether that increased investment has reached its intention, as you ask. I think it'd be interesting to see how that reports in the next couple of years.
I'll maybe come back if I can, yeah. So some of these wraparound services don't come from that budget, and that national mission won't touch that. So things that, as I mentioned, housing already comes from a separate budget, that is Scottish Government budget, for example. So, and we know that housing in Glasgow is particularly, it's not just in Glasgow, but housing in Glasgow is challenging, undoubtedly. So that's, one area that we can certainly kind of pick up on that isn't necessarily accounted for from the drugs budget or from the national mission, but is an area that certainly would need, ideally would be better funded to help support people.
Chair, following on from that, maybe it's too early to assess, but what level of service users of your safer drug consumption facility are effectively homeless? Because as you've advised, we're going through a housing emergency in Scotland. A number of local authorities have declared a housing emergency, and then eventually the Scottish Government, in the back of that, declared a housing emergency despite reducing their social housing capital budget. So what level of those using it are homeless?
We don't know yet, but I think you'll probably find that out, won't you?
Yes, so it's something we'll be looking at, but we don't have an answer for you at this time.
I just ask, will that be one of the metrics that feeds into the independent evaluation? That would be one of the
yes,
facts
it will.
that you
It will.
report on.
So earlier I mentioned this idea of assessing the reach, as it were. So which people are actually using the service and what are their characteristics. So that would be one of the things we'd look at.
Thank you.
Well, thank you. The next question is actually yours anyway, Douglas.
Yes, thank you, Chair. Drug-related death is a public health emergency. Glasgow has the highest level in Scotland, and Scotland has the highest in Europe. But despite that, I suspect there will be some elements of the media and public who will focus on the cost of the safer drug consumption facility and the pilot scheme. So really what I want to ask you is how quickly, how soon will we see an impact from your pilot facility, and what will success look like?
So in terms of so I think we need to remember this is kind of one facility among a kind of a range of approaches that are needed, and part of the way the facility will work is through building up relationships with the clients attending the facility. So certain outcomes could potentially change fairly quickly. So, for example, reducing the amount of skin and soft tissue infections could change relatively quickly, but still relatively quickly might take a little while for us to detect within an evaluation within a research study. So by that I'm talking about maybe kind of 3 or 4 years, that type of time period, to actually see those indicators change in a statistically meaningful way. Other things like bloodborne viruses are likely to change, but over much longer time periods, just because there's often a delay before those types of infections change enough to be really detectable, and the adverse consequences of that would then take time to feed through as well. So some of that we will get at by modelling what will happen over the longer time horizon to try and get an early handle on, or an earlier handle on, what the impacts are likely to be.
If I could address your point about, so you mentioned the public health emergency of drug deaths, so perhaps I was inferring you were asking about how quickly will we know if the facilities made a difference to Scotland's drug death emergency. I think it's important to clarify that the facility will address issues within the locality where it's located. So the facility is not going to address drug deaths in Lanarkshire, in Lothian, in Fife, in Tayside. It's perhaps not even going to address drug-related deaths in the rest of Greater Glasgow and Clyde. It will address the drug death risk for the people using the facility and the people in and around the locality who use drugs in that area. It's important to make that distinction, because I think
just on that point, but if there is a success in Glasgow, it's an argument to expand it across the country and to tackle the nationwide problem.
Yes, but again, as Vittal has said, it's important not to define success around a single metric like drug deaths. There will be a number of different metrics which this facility will be judged against, both at the individual level but also at the community level. And if the evaluation does show overall, when we look at these in the whole, that there might be some metrics that didn't play out as was intended. There might be some that did. Once that's all been assessed, and if the conclusion is that it has been overall a success, then I think it adds weight to the case for additional facilities, but only in areas where public injecting or public drug use is highly prevalent. There's no point in putting a drug consumption room in an area where you don't have a significant issue for that, because they are designed to deal with a very specific issue.
I think we're coming to the end of the session now, and we've talked a lot about evaluation. I just wondered, when you were speaking with my colleague, Mr McAllister, earlier, you were talking about the metrics that are going to be used for the evaluation and when we might see those results. But I wonder whether, if, for example, you were to recognise at a relatively early stage that there was a success in one very, very specific area, do you have the opportunity to make that known at an earlier stage to hopefully try and influence policy or practice wherever that might be relevant? Would you be able to do that kind of thing?
Yes, yes. So what we're planning to do is, obviously there'll be a period of collecting data over a fairly long time period, so a good kind of 4 years or so. But as we go along, we're planning to feedback interim results to the Health Board, for example, but also other key stakeholders in and around the area. We'll also be reporting more formally on research findings once we're confident in them, once they've been peer reviewed and so forth. Some of that, so all of the findings will be made available publicly in open access publications that anyone can access, but we'll also be offering to give briefings or report verbally to key stakeholders as we have findings, and as long as we're kind of confident enough that in them, then we'll be reporting them as we go along, including things like early learning about what types of things have worked well on the ground, what things have staff been finding successful in terms of engaging with clients, and some of these kinds of practical issues, as well as some of the actual changes to health outcomes as well, once we have those.
And I think it was mentioned that the pilot is for 3 years, is that correct? But the evaluation might take 4 years. Now, I can understand why that might be. It's a lot of data to process and a lot of thinking to do around that. But if it's clear that it's successful, do you think that there's an opportunity, all other things being considered, to continue the pilot? Will make it no longer a pilot, I suppose, and make it a prolonged opportunity?
So we anticipate publishing an interim report at around the 2.5 year mark, potentially a bit earlier, but by 2.5 years, and the actual overall evaluation will last 4.5 years. So we'd hope, part of the reason for timing that interim report is to be able to provide evidence to help inform whether the service should continue or not. So from the point of view of being an independent evaluator, if the service seems successful, then it's obviously up to the Health Board and the Lord Advocates and so forth to make a decision, rather than us as independent evaluators. But it would seem to make sense that the evidence suggests success, then that might be something appropriate to do.
Do you want to add something to that, Catriona?
Well, I do. It's maybe slightly off, but just because I'm aware we're coming to the end of the session, I suppose there is a point I'd like to make for the committee to consider if it's appropriate. But the Lord Advocate making this request for evaluation and making that kind of prerequisite, obviously we welcome the opportunity to have a site and to have that evaluated. But it doesn't help other parts of the country where there is potentially a need for some form of facility, not necessarily that to the level and extent of funding that the facility in Glasgow has, because it is a kind of gold standard level service that the people of Glasgow have got. So I guess I'd like to appeal to the committee to also consider what other options there are still available. We do have a very strong international evidence around the benefits of safe consumption facilities. Waiting for the Glasgow evaluation will be good to learn some of the nuances of what does and doesn't work, but it in itself delays potential developments in other parts of the country. And there are other levers available that could make those things happen, like considering the Misuse of Drugs Act and considering some reform to that Act which would enable other parts of the country, and that's UK-wide, not just in Scotland, to be considering and just opening the door for them to be able to do those types of services as well.
Going to take Gillian into here, but just to say that I'm sure that's one of the issues that will no doubt be considered by the committee going forward. But Gillian.
Yes, it was just a very small point just to come off Catriona's point there, is that the Lord Advocate is a really essential stakeholder in the Glasgow site, and opening other sites around the UK really would be supported by perhaps a shift in the Misuse of Drugs Act regulations, particularly around the offence of possession, because naturally to use a substance one must be in possession of it. There are, of course, other aspects of the Act, and it's not within the time perhaps to discuss those now, but changes to the regulations at a Westminster level would make it easier to support Scotland going forward in opening further services should there be a successful pilot around where there's areas of need in different aspects of Scotland.
Thank you. Thank you very much, all of you, for your time today. We're very grateful to you for coming along. We do have other sessions planned with other professionals involved or with an interest in the service, but we wish you very well meanwhile with it. We are going to be visiting ourselves as a committee very shortly, and we're looking forward to that enormously. So thank you again for your time, and I'll declare this meeting closed. Order.